a lot of clinicians with that same interest. If we can do that, how much better can that be? If we can have the ones that are working in the hospital setting now play a pivotal role in birth, how much better can that be? If we can have the ones who are an outpatient that may say, you know what, I don't feel like I want to be up on call and all these things, but what if I can deliver better education to my clients now that I myself as a clinician better understand, you know, the course of labor, now that I understand the interventions and the reasons and the rationales and all the things, now I can impart that onto my client in a way that they understand and they're better prepared. Because all childbirth education isn't created equally. We've got people that, you know, they're like, well, let's just go in and we just want to breathe and relax and all the essential oils and this and that. And that's fantastic, right? And that speaks to so many people. However, they also need the reality of what to expect when they get there. How to navigate this when you get there. What may be suggested or may not be suggested. How about we start this in the first or second trimester so you can get all the questions that you need asked so you're not in for the shock and surprise when you wind up at the hospital. So things like that. What the research says, because there's so many misconceptions out there. Oh, we need to break your water to progress your labor. Well, we all know the research is pretty ambiguous about that, and it really doesn't show that there's any benefit to rupturing, you know, to rupturing the membranes. So, but yet and still, the doctors are still doing it. The research, you know, ACOG does not support induction unless it's medically necessary. But we have doctors saying, well, I'm going to induce you at 39 weeks just because. Well, why? There's no medical need. But people aren't aware of that. That ultrasounds are 15% hit or miss. So you can, you know, they tell you, oh, you're going to have a big baby. Well, ultrasound is going to be off by 15%, right? So now you might likely have a 7-pounder and not a 9-pounder that they're telling you, but they're saying, well, we got to do a C-section because your baby is big. And then they pull out a 6-pound baby and you subjected this person to this level of trauma for no reason, right? But the research is there and we know it. So if we say we're going to follow the research, then let's follow the research, right? But there's so much inconsistency even there. So our goal is to also get the clinicians on board so that they're aware of this. And again, I can't do this all by myself. So if I can impart this to other people wherever they are, they can start plugging this in. How much better is that going to be for people in the community? And then as a Black woman, I also recognize that the people in the hospitals that are serving don't look like me. You may have some Black nurses, but the charge nurses by far and large are not going to be Black. The managers, the department managers of women's services, by far and large are not going to be Black. The C-suite is definitely not Black. So the people making the decisions, the people with the policies in the hospital, the people that matter don't look like me. And they're making the rules for people that look like me. And that's problematic because they're not in touch with the people that they're serving. And we need more people to be aware of that.